This will be recorded. All right, so good afternoon. Welcome to the training filing an Illinois Medicaid claim for the Diabetes Prevention Program, a how-to guide. My name is Jana Simon. I'm the director of our Center for Policy and Partnership Initiatives at the Illinois Public Health Institute, and we're excited to have you all join us today. Before we launch into having our trainer take us through this, I just wanted to remind folks a little bit of the background of this project and recognize our funders as well. So if you've been to either of the two first trainings we've held, we are really working in collaboration here at the Illinois Public Health Institute with both the Illinois Department of Public Health and in consultation with the Illinois Department of Healthcare and Family Services to really work on supporting implementation of Medicaid coverage for the National Diabetes Prevention Program and diabetes self-management education and support services here in Illinois. That has been part of a multi-year project here to really elevate and connect and scale the systems related to the diabetes prevention program and diabetes management. And there are a couple of Centers for Disease Control and Prevention grants, both at the state level and in Chicago, that have been helping to scale these programs, especially the diabetes prevention program. And we've had lots of technical assistance as well nationally through the CDC 618 initiative. And that was with support from the National Association of Chronic Disease Directors. So there is a lot of momentum and interest in helping to scale the diabetes prevention program here in Illinois. And also Medicaid has indicated coverage of that service as of August 1st. And so we're really excited to bring to you today these trainings to help you one, enroll in Medicaid, which is what the first training focused on. And today is really to focus on how to actually submit a claim for the diabetes prevention program in Medicaid. So I'm really excited to have with us Lindsay Artola with Sage Health Strategy, and she is going to take us through the training today. And so Lindsay, I will go ahead and turn it over to you.
Let me just get my screen share going here. Okay, everyone can see, I hope.
Yes, thank you.
And can hear, great. All right, well, welcome everybody, and welcome back if you were at our previous trainings. We are going to focus today on billing for the diabetes prevention program services. And this is really just for the Medicaid managed care organizations. So it's not fee-for-service billing to the Department of Healthcare and Family Services, but really focused on the Medicaid MCOs, managed care organizations, which the vast, if not all your clients and patients will be members of one of the MCOs. So in terms of an agenda, we're just going to talk a little bit about who those MCOs are and some tools and resources available to you. We are going to spend a couple of minutes talking about Medicaid eligibility and enrollment. One of the most important things when it comes to billing is making sure that whoever you are providing services to and billing for are eligible or currently eligible for Medicaid, and that you have the right information in terms of which MCO they belong to. Then we'll go into actually how to set up your organization to bill and file claims for DPP services. And then we'll just spend a little bit of time at the end on common billing errors and how you can go ahead and fix them. And we'll make sure that there are time in between each of these sections to ask some questions. I think you're all muted, but Rebecca is monitoring that chat box. And so she will make sure that we address your questions as they come in. So first of all, just want to do a review because many of you are probably new to the Medicaid program in Illinois. It is administered by the Department of Healthcare and Family Services. The program here in Illinois is called Health Choice Illinois. So you'll often hear folks talk about the Health Choice program. That is the Medicaid program here in Illinois. And the state contracts with 5 different private, I shouldn't say, they're not all private, obviously county care is not, but 5 health plans or managed care organizations. 4 of those serve members across all 102 counties. That's Aetna Better Health, Blue Cross, Molina, and Meridian Health. They are in all 102 counties in Illinois. And then finally, we have County Care, who is only managing members in Cook County. So if you do not do business or serve folks in Cook County, you will not need to, nor will you want to contract or deal with county care. You'll focus on the other 4. So those are the 5 players that, you know, most, if not all, of the Medicaid members you deal with will be coming from. The other resource I want to make sure that you are aware of is all of the health plans in conjunction with their state association, the Illinois Association of Medicaid Health Plans, known as IMHIP, have developed and published a general and comprehensive billing guide based on your provider type. So it is posted on their website. The link is right here at the bottom. And it is updated on a regular basis. In fact, a new version was just posted a couple of weeks ago. And it's just a very great resource just on general claim submission information. There's a lot of contact and resource information by health plan in there. Some great appendices. And then, although it's not on this list here, we will be developing a chapter specifically for these 2 new diabetes programs. And so, you know, you'll do this training today, and then it'll become time to bill for some of your clients, and you'll have forgotten it all. You'll be able to go online, and all the information that we go over today will be in that comprehensive billing guide. So I wanted to make sure that you were aware of that. So let's jump into eligibility and enrollment and why that's so important from a billing perspective. The number one reason claims get rejected or denied is because the member was not eligible on the date of service or had switched plans and you're billing the wrong health plan. So it's really important that as you start this process, you put controls and policies and procedures in place right from your registration desk when folks come in or start registering for service. So it's important to know that the MCOs themselves do not determine Medicaid eligibility. That is done by the Department of Human Services and HFS collaboratively. So they are the ones that determine whether an individual is eligible for the program. And then once they're determined to be eligible, they meet the income or clinical criteria to be in the Medicaid program. Then a client enrollment broker known as the Illinois Client Enrollment Services works with those individuals to choose a health plan. So the health plans themselves are not responsible for either determining eligibility or which health plan that member is assigned to or chooses. So every Medicaid eligible enrollee is either chooses a health plan. They always have the choice to pick the health plan they want to be in. If they do not choose a health plan, then Client Enrollment Services will just assign them to one. So again, Medicaid eligibility is determined by the Department of Human Services. There's income requirements. You can qualify based on a disability or age, or if you're pregnant. And that is all determined by DHS. And then once you are enrolled in Medicaid, then you get to choose your health plan, or you're assigned to a health plan through Illinois Client Enrollment Services. So if you have eligibility and enrollment questions or concerns, the MCOs really have nothing to do with that. You're really dealing with the state of Illinois. So it's important that you know that. And as I said, the top reason for claim rejection and denials is that the member is not eligible. So it's really important when you begin offering these services to Medicaid clients that you have an intake process that checks for eligibility and enrollment every time. And you can do this either through asking the member for their ID card, and you can see samples of what the different ID cards might look like over there on the right. But oftentimes, they will not have their card with them. They will have lost their card. The card's out of date. So we always recommend that you check what's called the Medi system, and that's the Department of Healthcare and Family Services enrollment system. It's an automated system. You go online, you can look up the client's name and birth date, and it will show you not only what date they became eligible for Medicaid, but what their current health plan is. And it's important that you document that you checked the Medi system, and if at all possible, do a screenshot so you have documentation that on this date, this is what the Medi system showed for this member, that they were eligible and that they were part of County Care or Blue Cross or Meridian. And having that documentation on the file, so that if you do get a claim denial, you can show that Medi said this person was eligible, and you can submit to get paid. So the Medi system is open to Medicaid providers. So, you've got your impact enrollment and all the rest of it. You can get access to the Medi system. You just make sure that you have the right employees, on that registration desk or however you handle registration, have access to the Medi system. You do have to get an Illinois digital ID. We've provided the links here below, so you can go in and just follow the steps. Again, it's not a difficult system to sign up for. You just have to, put your name, organization number, et cetera, et cetera. Fairly simple process to get yourself registered and up and running on the Medi system. And it's a fully automated system available 24/7. And again, just making sure that you train folks that are doing intake to check eligibility, and check it every time. Don't, this is a year-long program. It's really important that you check that eligibility each time. People will lose eligibility mid-year. They may switch plans depending on when their open enrollment period is. So it's important to build in that rigor of checking eligibility and enrollment each time you interact with one of your clients. Any questions on eligibility and enrollment before we move into the meat of today's training? If any of you were on the previous training, it's old news, the eligibility and enrollment, but we wanted to make sure to cover it.
Nothing's come through the chat box so far.
Perfect. All right, so let's move into setting up to bill. So let's just quickly review the program itself. If you were part of the training on DSMES, then this again will be old news, but worth repeating. Every provider has to obtain a new NPI and enroll in the impact system using that facility agency organization enrollment type, FAO, with a specialty of diabetes prevention program and that taxonomy code there, the 174H. So, you may have done this for DSMES. You may already be enrolled as an FQ or a hospital outpatient provider. Everybody who wants to provide these diabetes services must obtain a new NPI and have a separate enrollment for the diabetes services that are coming on, that came online on August 1st. So we just want to make sure we repeated that because we've had a lot of questions about it. For the DPP program, the members are eligible if they are between the ages of 18 and 64. So it's just the adult population. And they have to have two other criteria. They have to be considered overweight, clinically considered overweight or obese. And you can see the BMI designations there that count as overweight or obese from a clinical perspective. And they have to have either elevated blood glucose levels or a history of gestational diabetes or GDM. And you can see the criteria there for what they consider elevated blood glucose levels for prediabetes or GDM. So those are the criteria. They have to be an adult between 18 and 64, be clinically overweight or obese based on those BMI levels, and either have the elevated blood glucose levels or gestational diabetes. Unlike the DSMES program, members for this program do not require a referral. They can self-refer into the program. So you don't have to worry about having a physician referral into the program. But also similar to the DSMES program, if they do have Medicare coverage, you know, there are folks that are under 65 that qualify for Medicare for other reasons. And so they may have Medicare coverage. You always have to bill their Medicare provider first before you bill Medicaid. Medicaid is always the payer of last resort. Not many people will fall into that category, but it is important. Otherwise, you're going to get a denied claim. If they have Medicare coverage, you have to bill the Medicare program first. Here's how the program gets reimbursed. It's all based on milestones. There are 5 milestones and then a final performance payment. So you can see in the table here, there are HCPCS codes, or those procedure codes that go with each of those milestones. So for milestone 1, they have to attend their first core session of DPP service. There is a payment attached to that milestone. Milestone 2, the member has to have completed 4 total sessions. And again, there's a payment attached to that. Milestone 3 was you can submit the claim when the member has completed 9 sessions. And then when we get into milestone 4, they're starting to look for some weight loss and some performance objectives. So there's 2 different codes that you can use when the member has completed 2 sessions in the months 7 to 9 of the program. And the payment and the code will change depending on whether the member achieved 5% weight loss or not. So if they attended 2 sessions in months 7 through 9 and did not achieve the weight loss, you're going to use the HCPCS code G9876. And if they did, then you can bill for code G9878. And again, the payment differs based on whether that weight loss is achieved. Same thing for milestone 5. It's the those final 2 sessions in months 10 through 12. And again, the payment and the code will change depending on whether they achieved that 5% weight loss. And then at the end of the 12-month period, you can bill that final code if they have achieved that 5% weight loss from baseline. And that's a further payment of $100. The other thing I would mention, as you can see, all of the codes that are listed can only be billed once in a 365-day time period. So you have to make sure that you are using the correct code and that you only submit when the member hits that milestone and they've attended those sessions. And similar to the DSMES program, if and given where we are with the pandemic, a lot of this may be happening through either a virtual platform or through a telehealth modality like a Zoom or something similar. If that is how you are delivering your service, you have to use the GT modifier. Any questions on the milestones?
So we have a few questions coming in about the NPI number. So the first one is, what do you mean by saying that all providers must obtain a new NPI? A provider has only one NPI.
No, a provider can have multiple NPIs. This is it's an NPI, it's a type 2 NPI, which is an organizational NPI. So, and you can have more than one organizational NPI. It's a type 2. It's not a type 1 NPI for like if you were a doctor.
Great.
You can definitely have multiple NPIs as an organization.
And I think a lot of the rest of the questions were stemming from that. So we're saying the facility MPI, not a, individual.
Yes, I'm
provider.
sorry.
Mhm.
Yeah, and that's because with this program, there is no independent, like you're billing as an organization and you're providing the service as an organization, not a clinician. So there will nothing on the claim will indicate a clinician. It's all based on your organization. So you need a new organizational NPI. There are no quote unquote rendering providers. It's all based on your organization. So, and that to follow on to that, your individual clinicians do not have to register with Impact nor get a new NPI for this program. It's just the organization.
So someone's asking if the organization has a new facility NPI, do you still obtain a new one?
A new NPI for,
I think someone's saying if an organization already has a few facility MPIs, do you still need a new one for this service?
you do, yes.
And
Another,
then someone else asked, can you use a new MPI for both DSMES and DPP together?
Yes, you can. Yeah, it's just an NPI specifically for the diabetes programs, whether it's DSMES or DPP. Now, when you do your enrollment impact, you'll have to pick both of those specialties to attach to the NPI. But yeah, it's one new organizational type 2 NPI for the new diabetes programs, whether it's SMES or DPP. And individual clinicians do not need to get new NPIs nor register an impact, just the organization.
And there's one more question in here, which you might get to later, but someone says, is there a no charge G code to show the 2 sessions attended for milestones 4 and 5?
No, you just have to put it once, and the sessions attended, it will be like an audit process, a post-service audit process.
that seems to be it for now. Thank you.
Okay. And I should say, related to the G codes, one of the things that we still, it's a new program. And so the department and Jana and the folks involved in pulling this together, there's still some kinks to work out, I would say. And so we are presenting today based on what we know today. We do have a similar question about the G codes when you're billing for multiple sessions attended. But this is the guidance we've been given today, and certainly, keep your eye out for those provider notices. But this is the way it has been set up for today. That could change like any other provider billing procedure, but for today, that's where we stand. Most of this will be done in a sort of a chart audit on the back end, if the MCO feels they need to for whatever reason. But that's pretty standard too.
And we have one more question that came in. Can you build multiple locations under one new NPI?
So are you talking about like you're an FQHC that has multiple locations? Yes. Yeah.
They confirmed that yes.
Yeah. Mm-hmm. And I'll show you on the claim how to do that. Okay, let's move right along. As we mentioned, diagnosis codes are important in this program. And there are 4 diagnosis codes from a diabetes perspective. So from the clinical glucose levels or gestational diabetes perspective. 3 of them are R codes. Those are the ones related to elevated blood glucose levels. You can see them there in the description of them and the definition of each of those diagnosis codes. And then the final code is a Z code, which is related to the gestational diabetes, the history of gestational diabetes. And you can see the definition there. There's 3 different ways you can identify whether there is a Z code present. Either they present a referral from a clinician, a provider that shows a Z code diagnosis. You may receive blood test results from a provider or from the member's MCO that indicates that. Or you could have a member or client that presents with some independent blood test results and a provider note indicating the history of GDM, or that they have a normal A1C or glucose level, but they have had gestational diabetes in a previous pregnancy. So those are sort of the conditions or the definitions of that Z code and when to use it. And then this is a bit of a chart that'll make your eyes cross. But these are, remember in that criteria, you have to have two different conditions in order to qualify for this program. One is your elevated blood glucose level. The other is being clinically overweight or obese. And that's indicated by a BMI measurement. And these are the different codes based on where the BMI falls for that individual that you would use. So again, if they were between 27 and 27.9, you're going to use Z code 68.27. If they're between 33 and 33.9, you're going to use Z code 68.33. So a lot of codes, but fairly simple to follow. It's just a chart to follow based on their BMI measurement. So how do you use the diagnosis codes? For the initial claim, for the very first claim that you send in to an MCO, you have to indicate two ICD-10 diagnosis codes. One that indicates the patient or the member is presenting with elevated blood glucose or a history of gestational diabetes, and that their BMI level falls above the 25 or 23 if they're Asian. And so in that initial claim, you have to include both of those diagnosis code, either an R code or the Z gestational diabetes code and a BMI level code. For any claim after that, so when you're doing milestones 2 through 5, you only have to provide that R or Z code indicating the elevated blood glucose or gestational diabetes. You do not have to include a BMI diagnosis code on any of those other claims. So that first claim has to have both, so the MCO can see that they qualify for the program. After that, you only have to include that diagnosis code indicating elevated blood glucose. Make sense? All right, the final key claim element that you need to know is place of service. So the MCO is going to need to know, where was the service delivered? These are the eligible service codes that you can use. So you can provide it either through telehealth or a virtual platform. School, homeless shelter, you can see here, don't need to read them all. The 99 code, if you recall from the previous session, would be if you are providing it in, providing the services in a community setting like a YMCA. Maybe you have your clients all meet at a public library, wherever that setting might be. And that also includes hospital outpatient programs would use place of service code 99. Remember that if you do provide this service using telehealth or a virtual platform, you have to include that GT modifier on the claim.
All right, Lindsay, I think on the last training we had said hospital outpatient should use Office 11.
Oh, I'm sorry. Janet, forgive me. Thank you so much for catching that. You're absolutely right. You're absolutely right. Forget what I just said. 99 is just for those community-based organizations delivering service in a community-based setting. If you are a hospital outpatient department or outpatient program, use place of service code 11. Thank you so much, Jana.
Mm-hmm. Can I go back to the last slide just for a minute to point out that you can assign, if you're a community-based provider and you're not a clinician, your authorized to assign an R code based on those 3 criteria in the middle there if a member brings you their blood test results?
Yes, yeah. Yeah, if the member shows up and they've had a blood test, you know, and they bring you the results and you're able to identify based on those blood test results where their blood glucose, oh my gosh, blood glucose level is, and it falls within the category, you know, the definition that I showed on the previous slide, then yes, you are more than able to assign that diagnosis code.
Thank you.
Okay, so let's start with how are you? So those are what I just went over was really those key claim elements that it's really important you understand. So you need to know the milestones in those HCPCS codes and what you're going to be billing for. You need to understand those diagnosis codes. And, you know, on that initial claim, you're going to have to show both. And then you need to know place of service. Those are key elements that the MCOs are going to be looking for on the claim to make sure that it's appropriate for the service. So how are you going to go ahead and file a claim? 3 different options. You can file paper claims, and the form you use is called a CMS 1500. You can file claims electronically. If you are a larger organization that's already billing Medicaid, you are probably already submitting claims through a clearinghouse using what's called the 837P format. And you can also submit claims with the exception of one plan through their portals. Each MCO has what's called a provider portal. We'll talk about those in a little bit. And there is the ability with some of the plans to just file claims directly through their portal. So you just key it in through their portal. And how you decide which method to use is really going to vary by organization. So as I said, some of you are probably larger organizations that are already billing Medicaid. So, you know, more than likely you're already doing electronic submission. Some of you have never billed Medicaid and don't have those systems set up. So maybe you're going to be using paper claims or, you know, going through the portal. It really depends on how many claims you think you're going to be submitting on a regular basis, what your individual organizational capabilities are. And then the other thing to point out is as you start to, if you've never contracted with one of these MCOs, make sure when you're talking with them and reviewing contracting language, some of them will have contract language in that requires you to submit claims in a certain way. Usually it'll say they want you to submit them electronically. So you just need to make sure if the language is in there and you're not set up to do that, you know, just be on the lookout for that kind of contract language to make sure it matches what your capabilities are in terms of claim submission. And again, some of you may be already billing Medicare, so you're already familiar with the CMS 1500. So it really depends on your organization and how much billing you actually do. If you are going to submit paper claims, there are some key do's and don'ts. I'm not going to read them all. What I would tell you is most important, well, all of them are important, but just remember that if you are filing paper claims, you have to use the original CMS 1500 red and white form. You can't just photocopy and send in a photocopy. You have to use the original CMS 1500 form, and it has to be typed out. You cannot, you know, handwrite in, excuse me, handwrite in the information. So really important that you definitely use those original forms. And it's one claim per member. You can't put multiple members, you know, if you're doing a group class, you can't put all of those people on the same claim and bill all of them at the same time. It's one claim per member or per client. Oops. If you're going the electronic billing route, which is definitely preferred by MCOs, but certainly not mandatory. Couple of things to think about or process that you would go through is, you know, you have to have a clearinghouse that takes in all your claims and filters them all and gets them to the appropriate MCO. So you have to have a clearinghouse that you work with. Obviously, you're going to tell them that you are going to be submitting claims to MCOX, MCOY, and MCOZ. And that you've got the right file format, sorry, for them to accept those claims. You're going to start submitting the claims to the clearinghouse, and they're going to give you 2 reports on a daily basis, or however often you submit claims. The first report is going to show which of those claims that you have submitted have been transmitted to the MCO, and which of those claims have been rejected by the clearinghouse. So the first filter, if you will, is at the clearinghouse level. They have a set of data fields that they are looking for to be filled out and filled out correctly on that claim. If they are not, they're not going to send it on to the MCO. They're going to spit it back out to you, and it's going to show up on this report that says these were not submitted to the MCO. You need to fix these and send them back in. So those are called rejected claims. And then it's also going to show you which claims went through and were sent to the MCO. The second report that they send you shows of those claims that were sent on to the MCO, they made it through the clearinghouse filter and they sent them on to the MCO. For one reason or another, the MCO has rejected those claims. They have some claim edits and processes in place before they will accept a claim into their system. And so you can get your claim rejected at the MCO level. So again, you're going to have to correct those claims and resubmit them. So it's really important that if you are going to submit claims electronically, that you're reviewing those reports so that you know that your claims were accepted and sent to the MCO, and that the MCO has accepted them into their system in order to process them. So that's those 2 reports. You really have to stay on top of those. We've had a lot of providers that say, my claim's not paid, my claim's not paid. And they haven't been looking at those reports, and the claim hasn't been paid because it never got to the MCO. It was rejected at the very front end. So really important to be looking at those reports. And then finally, I mentioned the provider portals. You can see here the links to each of the provider portals. With the exception of, I believe it's County Care. Yes, County Care. All of the MCOs allow you and have the functionality within their portals to submit claims directly through the portal. So it's basically just key in information right through their portal and directly submit it that way. So that's another option that you do have, again, depending on how many claims you're going to be submitting. You may want to, we suggest always signing up to be part of their portal anyway, but you may want to use that route to submit claims if you don't want to go the paper route and you don't have electronic capability. This is another option that you do have. Any questions before I get into actually filling out the claim form, Rebecca?
No, nothing's come through. Thank you.
Okay, perfect. So these are just some of those, when I think of when we talked about the rejections, these are some of the things that you have to make sure are on that claim, or it's going to get rejected on the front end. Really important, again, this goes back to your impact enrollment, that on the claim, your TIN number, your tax ID number, and the new NPI number, that type 2 NPI number that you've gotten, and that taxonomy code all match what you submitted in your impact registration and enrollment. So the TIN, the NPI, and the taxonomy code have to match that impact provider or impact registration. Obviously, you have to identify the patient. You have to include their name, their Medicaid ID number, their address, and their date of birth. The date and place of service has to be on the claim form. And again, the diagnosis codes that we talked about, the procedure code, any modifiers, and those place of service codes. So those are sort of those key elements right from the get-go you have to have on every single claim that you that you send in. And I mentioned before, if they do have Medicare coverage, you do have to bill the Medicare program before you can bill the Medicaid plan. So here's a picture. This is what that paper claim looks like, that red and white CMS 1500 form. It's the same form that you would use for Medicare. So if you're already billing Medicare, it should look familiar. I've put here, excuse me, there is a manual. The link is right here. It goes field by field by field to tell you what goes in each of the different boxes. So it's a really good resource to have. You may want to bookmark that one if you're new to the CMS 1500 game. And then just a reminder of those key claim elements and where they go. So here we have our diagnosis codes. They're going to go in field 21, and I'll show you this in a sec. So that's field 21. Again, have to have these diagnosis codes. Field 24D is where you're going to put your HCPCS code and modifiers. HCPCS codes. And field 24B is the place of service code. So again, all of these key elements have to be on the claim. So let's just take a look. So here's the form all filled out. Field 21, here's the date of service, et cetera, et cetera. I think I have the next. Yeah, so here's the top of the claim, because the last one, it's too hard to read. This is the front of the claim. So here we have, obviously this is a Medicaid claim. Here's the name of your patient, their date of birth, their sex. Here is their Medicaid ID number. It says insured's ID number. That is going to be their Medicaid ID number that is on their Medicaid card or shows up in the Medi system. Got to make sure that is on the claim. Their address and their phone number. Important, you cannot have any punctuation in the address and phone number. So you don't want to put any dash in the phone number, any periods after, a directional indicator or the street or avenue, no punctuation. You're always going to have the self for Medicaid coverage. And again, same thing, their address, date of birth, gender. Employment, auto accident, other accident, these will all be no. And then here you're going to put the MCO name, whether it's Blue Cross, or Meridian, Molina, you're just going to put that in that. What is this one? What number are we at here? Too many numbers. 11C. In box 14 down here, date of current illness, injury, or pregnancy. It's going to be the first date that you saw the patient. Even on the subsequent claims, it's always going to be that first date that they began in the program. So in this case, it's September 26th of this year is when they first came in to be part of the DPP program. And that's not going to change in any of the subsequent claims. It's going to be the date of when they began the program. We look at the bottom of the form. Again, here's box 14, that date that they began the program. Here are your diagnosis codes. So in this case, it's R7301. It's the elevated blood glucose levels. Here's their BMI. This is an initial claim. So here's their BMI diagnosis code. I just realized, I hope folks can see the arrow. I'm pointing at things. I'm not even sure you can see that I'm pointing.
Yes, we can.
Okay, so 24A is your date of service. So this is an initial claim. So they came in for service on 9/26/21. They had their first core session in an office setting. And that it's the initial claim. So it's that first milestone, G9873. If this had been a telehealth visit that you guys met them through a Zoom call, your place of service would become O2, right? It's that telehealth place of service, O2. and you would put the GT to indicate telehealth in this modifier box right here. But because this was an office visit, there's no modifier. You only have a modifier if it's telehealth and it's GT. It's always the same modifier, GT. Box E is called the diagnosis pointer. And they just want to know, for this particular HCPCS code or procedure code, what is that relating to from a diagnosis perspective? So in this case, it's both of these diagnosis codes. So you just put A, B. Subsequent claims, you're not going to have this BMI one because you only need the diagnose, the R code. You'll just put A, you won't need to put B, but it just wants to know that of these diagnosis codes, which procedure code is relating to them. Then you're going to put your amount depending on the milestone. Again, that'll change. Number of units is 1 because the milestone is 1 unit. You don't have to worry about rendering providers on this, right? This is all being done as an organization. So you don't need to put, my dietitian or my diabetes educator or whoever. You don't have to put anything in box J. 24J can be left blank. It's all being done at an organizational level. Similarly, if you were part of the DSMES training, you remembered we spent a lot of time talking about referring providers because that program requires a referral from a provider. You do not need to fill anything else. Even if it was a physician sent them to you to take part in this program, you do not need to put anything in this box. So you can leave that blank as well. Box 25 is going to be your tax ID number. Whoops, sorry. Your tax ID number, again, no dashes. So it's not going to be 46 dash. It's just going to be all straight up, indicate that it's a EIN, not an SSN. If you have a patient account number, it depends on what your revenue cycle system looks like. You may have an individual patient account number. That's something that you can, would be from your systems. Yes, you always want to put yes for accept assignment. Total charges. Here's the other important element. Again, this is your organization. It's always going to be the organization that is tied to that new NPI number, the new type 2 NPI number that you put in there or got the NPI number for. This is going to be your Medicaid ID indicator. So when you get your impact registration, it's going to give you your Medicaid ID to show that you are registered in impact. That's what you're going to put in box 33A. And in 33B, you're going to put the taxonomy code. And you can see here 174H. You have to preface it with ZZ. There's different numbers that can go in here. It can be a license number, depending on the type of provider, because this is a general claim form for lots of different types of providers. You want to make sure you put the ZZ in front. That tells the claim reader that this is a taxonomy code, not some other type of code. So remember your tax ID number, your Medicaid impact ID number, and that taxonomy code number all have to match what you put in the impact registration. And then for the individual that asked about if you're providing services at a different location, again, if it's telehealth, just put your regular organization name in here. But if it's, if you did it at a satellite location, you can put that information here if you want, but it's not required. I think for simplicity's sake, what the claim and what the MCO wants to see is just who's billing it. And do they have an appropriate enrollment in impact with that taxonomy, with that tax ID? Any questions on the claim form?
No questions at this time.
Wow.
I want to give folks a minute to put them in the chat. If you have them.
There's the bigger picture so you can kind of see all the elements. Oh gosh, I completely misspoke. This is your NPI number, not your Medicaid ID number. I can't read my Box 31, box 31. Let me go back because I can't, my eyes aren't good enough. Where is box 31? Oh, 31 is just the signature. So you have to sign and date the form. I apologize. That's sign and date the form. So whoever has responsibility for submitting the forms. Usually if it's a physician would sign it, but in this case, it would be whoever you have designated as your signatory.
So someone's asking if an OP program did a DPP at a community center, would we list the 99 location and then add the other location on the bill?
Sorry, let me just see this. If an outpatient, so this would be a hospital program when you say outpatient?
Yes.
Yeah, I would put the 99 location. Your place of service would be 99.
And then they're asking, in addition to that, would you then add the community?
Oh,
location
no,
to the
you
bill?
really don't. I mean, you could, but the claim reader's not going to be looking at that. No, you really only have to put the information in box 33. So if you put, where's the place of service? So you put 99 in there, and then you can just put this, the regular information in there. And then the only other thing I would say about claims, and we talked about, this the last time, is that, timely filing is really, really important. You have 180 days from the date you provided that service to get the claim in. And to, if there are issues like, you do get a claim rejected for one reason or another, that 180-day clock, as soon as you provide the service, starts ticking. So it's really important that you get claims timely out the door. Any other questions on the claim form? Again, these are the key fields that you want to make sure that you're filling out. These are what the MCO is going to be looking for to match.
I guess, Lindsay, if you're doing this in one of the electronic formats, would it look like this? Or
It
does
would
it?
not. The electronic format is, it's all gobbledygook. It's different loops and fields, and there's a whole, when we do the billing guide, it'll follow the same format and it's looking for the same elements for sure. It's going to want all of the same elements and all of the same elements to match, just like it would on a paper form. It's just what it looks like and how you submit it is just very different.
Okay. Thank you.
Yeah, they use what's called loops instead of fields. And it's kind of a gobbledygook kind of, it looks like code, if you will, if you're doing computer coding. All right, well, with that, then I'm going to turn real quick to just, I thought maybe I had a fire alarm going off here, but something else. So let's just quickly talk about claim disposition, and it's inevitable. I hate to say it. You're going to get some claims that get rejected, and you're going to get some claims that are, get denied for one reason or another. So let's talk about that. So there's two dispositions, or two results of submitting claims. You're going to get claim rejections, which means, as I said before, when a claim is rejected, it never gets to the MCO. Denied means it's gotten to the MCO and they've adjudicated it and there's something wrong with it. So let's go through those. I do want to mention that there are timely adjudication standards that the MCOs have to meet when they process claims. So they have to process 90% of clean claims that's processed within 30 days. And 99% have to be processed within 90 days. And that's clean claims. So that means that it, was submitted in the proper format for an eligible member, for a eligible benefit, and that, it hasn't been, that it has all the information on that claim in order for the MCO to process it. The other thing is, this is just processing claims. These time standards are just for processing claims. Doesn't necessarily mean they have to pay you within 30 days. Payment comes after the adjudication and the processing. So I just want to make sure that was clear as well. So again, a claim rejection is when the claim, you get rejected before it even goes into the MCO for payment. It's usually related to missing fields, maybe some alphanumeric twists in some of the data you've inputted, or completely invalidated, like you've, I don't know, put in a different G code that doesn't even exist for some reason. And as I mentioned earlier, you can get rejected in two different places. One from the clearinghouse, where the clearinghouse says, nope, you forgot to fill out these two fields, or it gets through the clearinghouse process and then runs up against a filter that the MCO may have. When you get claims rejected, you are going to hear it from the clearinghouse. You will not get any communication from the MCO, because the MCO doesn't even know that claim exists yet. It's been rejected on the front end. It's never made it into their system. A claim denial is when the claim has gone through and into the MCO's claim processing system, but there's been a problem as they go through that adjudication process, and they cannot pay it for some reason. And that's called a denial. And you are going to be notified by the managed care organization if your claim is denied. So rejections are from the clearinghouse. Remember, you have to look at those reports to see which claims were rejected. And then a claim denial is it's gotten to the MCO, it's in their system, but there's a problem with the claim, and you're going to hear about it from the MCO. And this is just, you can look at this at your leisure when you want to go to sleep at night. Just sort of gives you the process of how the claims flow through the system and what you do if there's a rejection. And I want to make sure we have some time at the end for questions. So these are the most common reasons for a claim to be rejected, again, spat out on the front end. Some of these will not be valid for you guys, admission type and patient status. These are all related to hospital billing. The big ones are, date of birth is missing. You've forgotten to put your TIN or your NPI on. If you're filling out those paper forms, haven't used a font size that's readable, maybe you're missing a diagnosis code. So these are some of the most common reasons a claim will get rejected on the front end and never get to the MCO. If you get a claim rejected, all you have to do is, make the corrections, add the data that might have been missing, correct whatever data they tell you is wrong with the claim, and then just resubmit the claim. And that's considered just a brand new claim. So again, a rejected claim is just, correct the errors and resubmit it. So again, a claim denial means it's made it through the filters, it's not been rejected, it's gone into the MCO's claims processing system, but there's some other reason that they cannot pay the claim. There's something wrong with the claim, and so it's going to be denied. And in that case, you're going to get something called an explanation of payment from the MCO. Very similar to, we all get an explanation of benefits from MCOs telling us, what got paid and what didn't get paid when we go to the doctor. This is just what they have paid of the claims that you submitted, what got paid and what didn't get paid and why didn't it get paid. So you want to keep an eye out for these explanation of payment letters. most common reason that claims get denied is the charges that you've put on there are missing. Again, those TIN or NPIs don't match what is in the impact system. Place of service code is invalid. So again, you can't put in a place of service or provide a service in a setting that's not allowed. And this is a biggie, member not enrolled on date of service. Eligibility is important, and that is the number, and I can tell you, number one reason claims will be denied is this member not enrolled on the date of service. So again, keep an eye out on that front end to make sure that when you're providing the services, they have up-to-date eligibility and they are with that plan.
And Lindsay, would that be true if you got the MCO wrong? So they were actually enrolled.
Same thing. Yep, same thing. Because similar to all of us, if you have employer-based insurance, you have that open enrollment period where you can choose a plan. Medicaid recipients follow a very similar process, but in the case of Medicaid, unlike us, where it's always we're always in the fall that we have open enrollment, theirs can change depending on their anniversary date of when they first became eligible for Medicaid. So sometimes, if you think about, you guys are providing service over the course of a year, they're going to hit an open enrollment period and they may change plans. And so it's really important that you check every time that they're with that plan still, or that they haven't changed plans. The other thing that can happen sometimes is, they have to, it's not so much now under the public health emergency because the state suspended redetermination, but in normal times, if you will, every year Medicaid enrollees have to certify or have to resubmit paperwork to show that they're still eligible, that they still meet those income requirements. And, sometimes they don't do that and they'll get dropped from the program because they haven't provided that paperwork. And then when they find out they've been dropped, they go in and quickly get the paperwork together or reapply. But when they get eligible again, they, for whatever reason, get assigned to a different MCO. So that's why that eligibility piece and that enrollment piece on the front end is so important. Just like, a private insured person can lose eligibility or switch plans at the end of the year or whatever. So, I can't remember the last time I've gone to the doctor and they haven't asked to see my insurance card. It's, you kind of have to do the same thing with the Medicaid program. So as I said, you're going to get explanation of payments. Some plans call it remittance advice, but it's just going to show you for every claim that you submitted, here's the member's name, when the service was provided, and what you billed, what was allowed to be billed, what was paid. And then it's going to give you adjustment codes. So if you're, for some reason, your claim was denied, you're going to go to these adjustment codes and it's going to tell you why that claim was denied. So it's going to just show you, oh, we didn't get paid because we didn't do XYZ, or the member wasn't eligible, or whatever that is. It's going to show you in those remark codes. And so it'll tell you, what you can or should do in order to get paid or reverse that denial. But again, that 180 days, that clock is still ticking. So in this letter, it's going to tell you if you don't do something within so many days, that claim will remain denied. So you have to, again, don't hold those claims, start getting them in. So if you do get rejections or denials, you can take care of it in the appropriate time frame. So this just shows you what a typical EOP would show. You can see the procedure code, what you billed, based on your contract, what they're going to pay you. This is obviously for, all the, like a Blue Cross that has commercial business, deductibles, copays. There are none, obviously, in the Medicaid. So it'll show you sort of what you were paid total, et cetera, et cetera. Some of them can be a little gobbledygooky, as we know from reading explanation of benefit forms that we get from our own insurance card. So what we have in the comprehensive billing guide is an appendix that shows by plan what their EOP looks like, with a key to show you what each of these things mean on their particular EOP. So, you can see these letters down below here in the appendix. It'll say A right here. This is what that's referring to. B, this is what that means. So it's very easy to follow along. If you get remittance advice from a particular plan, it's really easy to go to the back of and find this appendix if you don't understand what some of the terms or fields mean. So great resource for you. If you do get a denial, you can file a corrected or replacement claim to correct that error. So what they're going to do is throw out that original claim and you're just submitting a replacement. So it's replacing that previous claim that got denied for whatever reason that shows on the EOP. So these are called a corrected or replacement claims. When you submit, remember when we talked about rejections, when it never made it in, that's when you file a rejected claim, it's just a brand new claim because it's never been really, as far as the MCO is concerned, it's never really been submitted. So that's when you get those rejected claims. That's a brand new claim. MCO never saw it. But when you have received your explanation of payment, it's made it into the MCO and they've said, oh, there's something wrong with this claim. You need to fix it. It's called a corrected or a replacement claim. Seems like semantics, but it is important because for claims that were rejected, the MCO doesn't even know it exists yet. So if you're trying to fight with an MCO over a claim that was rejected, as I said, they don't have it in their system. They're still waiting for that claim. So it's a new claim if you correct it and send it in. Again, that 180 days, that clock is still ticking. So you filed that initial claim, they've adjudicated or processed it, sent you an explanation of payment. You still, that 180 days, you got to file in that replacement claim within that 180-day timeframe. What happens when you file that replacement claim is the MCO goes into their system and deletes that original claim completely out of their system. And as it says, replacement claim, it replaces it with the information that you've put on that claim, the corrected information that you've put on the claim. The other thing they do is any money they paid on the original claim gets debited, gets taken away, and a new payment is issued based solely on that replacement claim. I'm not sure that this will really happen for the services that you guys are providing. It often happens where, say you submitted a claim for $100 and the MCO paid you $70. So they sent you an EOP that said you submitted a claim for $100 and we only paid you $70 because XYZ wasn't on the claim. And you say, well, no, wait, we did do XYZ, we just didn't put it on that claim. We're filing a replacement claim. What they do when they get that replacement claim and you corrected it, the $70 that they paid you, they're going to take that back because that original claim that paid $70 no longer exists. So they're going to take that $70 back and pay you the full 100. And that can get kind of confusing because a lot of people think, well, why don't they just pay me the 30 so that we're whole? And unfortunately, the way the claims processing system works, it doesn't really work that way. So just keep an eye out on that. But I think for the most part, the codes that you're billing, you should not run into that issue. The most important thing to know is they're going to delete that original claim and replace it with the new one. So you keep track of claim numbers so that you're tracking the right claim number. In terms of submitting replacement claims or corrected claims, each plan does it slightly differently. Most of them will give you instructions when they send you the EOP, but you can look in again in the manual, and it provides very specific guidelines by plan on submitting those replacement claims. If you don't follow that process, you run the risk that when you submit the replacement claim, they're going to think you're submitting it as an original claim, and they're going to think you're trying to double bill for the similar service. So they'll think it's a duplicate, and they'll just reject it or deny it. So it's really important that you follow those replacement claim processes. All this to say, hopefully you don't get any claim denials and you won't even have to worry about this. And the only thing to know to help prevent that issue of the MCO thinking it's a duplicate claim and you're billing for the same thing that you already billed for, is on the CMS 1500 in box, if my eyes were better, I could tell you, box field 22, you're going to put a 7 that says that this is a corrected claim. We are correcting a previous claim that we already submitted, and you're going to write the claim number. That's going to be right on that EOP. This is the claim number, so that when this CMS 1500 goes through, the MCO system says, oh, wait, this is going to void out this claim. And we know this is a different claim that's been corrected and replacing that original one. So when you submit that replacement, you just have to make sure that if we go back to the CMS 1500, you put 7 in field 22, that indicates it's a replacement claim for this original claim number. So the system will go in, it's going to find that claim number, void it out, and replace it with this new claim that you're replacing it with. And one last thing on before we start into questions is provider portals. These are really, really handy for tracking your claims and submitting them if that's the route you decide to go. So this is a table that just shows by plan. They all have portals. They're required to have provider portals, but it shows by plan the different functionality within their portals. And so you can see for all of the plans, you can go in and see which of the claims that you've submitted have been received. So you know which of them are being reviewed. You can see where those claims are in terms of their status. They've been paid, which claims have been denied, which ones are pending, they're still in process. And you can see, those remark codes. So you can look, wait, I had a claim that was denied. Why was it denied? You can actually go in and see what the reason was. So again, it just shows you what the functionality is by health plan. And I think that is it. So if we have any other questions, I am happy to take them now.
All right, we have a 2-part question. The first one is, when billing the primary insurance like Medicare, are services billed under the individual provider, or is it billed under the organization?
So if you are, I am not a Medicare billing. So if you have someone who is, you're billing Medicare for that service, you would bill it just like however you're billing Medicare now.
Yeah,
and again,
I will say specific to the diabetes prevention program, there's actually a process to become a Medicare approved supplier for DPP that you have to go through before you can bill Medicare for DPP. So you would want to make sure you've gone through that and you understand the full requirements for Medicare billing for DPP before you try to submit a claim to Medicare.
Yeah, and then you would follow the Medicare billing guidelines, and I am not a Medicare billing expert. So it would be whatever the Medicare ones are, yeah. But it is a separate certification, separate process, separate everything, so.
So the second part of that question, is box 24J also left blank for non-Medicaid billing?
And I think related to that, only Medicare and Medicaid currently cover DPP statewide. So, and there's 2 different enrollment processes for each. So I'm not familiar with, there might be a couple out there who are private health plans.
Yeah, I was gonna say, for Medicare billing too, I mean, I know it's not required for Medicaid. For Medicare, again, I don't know how they set their systems up. I don't know if there's folks maybe in the crowd. I know there are some folks that are already billing Medicare for this, but, and I don't know, you know, commercial payers or employer-based providers that you can bill for those, so.
Great. This is a long one, Lindsay, be ready. Who tracks the hours that the patient has completed so far during the year to ensure we bill accurately? Example, what if we billed G9875 milestone 3 before milestone 2 was completed? For Medicare, there's no online verification of how many hours a patient has used that year. We have to call our MAC and speak to a rep to get a patient's hours of eligibility left for the year. And Jill from Medicaid Policy Network did reply to this one. She said that we're working with HFS and the plans and coordinating when individuals switch plans.
Yeah, so Lindsay, I guess
If they had switched plans, I got it.
Well, I also think too, would an MCO deny a claim if you billed for milestone 3 before you try to bill for milestone 2?
Well, I'm trying to figure out why would you not have billed for milestone 2? You just forgot? I guess I'm trying to figure out. Or is this if the patient had maybe changed plans and so you don't know? I'm not really clear on.
Yeah, I guess let's answer it as if someone had changed plans for now, and otherwise
if it's because they've changed plans, yeah, that's something that we are talking with HFS about, because there's a similar issue in the sense of for durable medical equipment, when there's, you know, quantity limits and then the patient changes plans and they've already, you know, gotten their hearing aids or whatever the issue might be. But so we're still working through that with HFS. And we really don't have an answer, unfortunately, if the member has changed plans.
All right, another question. Does Medicaid require the DPP to be CDC recognized like Medicare does?
Yes.
Yeah.
And when you enroll, and this was in the first training, which I sent the link out in the chat box, but we can send again. When you enroll, you verify, when you verify your certification, you're putting your DPRP organization number, and you have to put in an expiration date. So you would put in 1 year after date of enrollment. You'll have to verify your DPRP number and each year. But you would just put your DPRP organization number from CDC into that space to verify your certification or your recognition.
No more questions have come through.
And we stay on for 1 more minute just to see if there's any final questions. In the meantime, we will be sending the PowerPoint slides, a link to the recording of today's webinar, and I will send you a link to where the other 2 trainings live on a website, so you can view the other 2 if you haven't been able to already. And of course, we'll link to the provider notice from HFS in case you want to look at that again in more detail. But thank you all for joining. I don't see any further questions, Lindsay, so I think that might be all.
All right, terrific. Thank you so much.
Okay, thanks everyone.